Hi guys, in our previous section we accomplished definition for malaria, its causative organism, the vector who is responsible for the spread of malaria, its pathophysiology, that is the life cycle of the plasmodium species, then its signs and symptoms, right? Anyway, today let us begin with treatment. So how we can manage malaria? So the primary goal in the management of malaria is the rapid diagnosis of the plasmodium species by blood smears. So that should be repeated every 12 hours for 3 days. So this initiates the timely antimicrobial therapy so that we can eradicate the infection within 48 to 72 hours, and we can avoid complications such as hypoglycemia, pulmonary edema, and renal failure, which is an important goal in the management of malaria. So, because these complications are responsible for increased mortality rate in malaria. Now, moving to the pharmacotherapy. So, here are the list of the drugs and their respective classes which are used for the management of malaria. The drugs such as chloroquine, amodiaquine, piperacin comes under the class 4 aminoquinolines, whereas mefloquine comes under the class quinoline methanol. Quinine and quinidine comes under the class cinchona alkaloid. So, biguanides such as proguanil and chlorproguanil are also used for the management of malaria, and diaminopyrimidines such as pyrimethamine, 8 aminoclonine drugs such as primaquine, bulaquine, and sulfonamides and sulfones such as sulfadoxine, sulfamethoxypyrazine, and dapsone can also be used for the management of malaria. Also, we can provide the care with the tetracyclines as well, such as tetracycline, doxycycline, and the most important alternative drug is the sesquiterpene lactones, such as artesunate, artemether, and artether. Amino alcohols such as halofandrine, lumefantrine, manitch base such as pyronaridine, and naphthoquinone such as atovaquone can also be used for the management of malaria. So here is the flowchart that depicts the easy classification of the anti-malaria drugs. So mainly there are 4 classifications: blood schizondicides that treat the acute attack, then drugs for radical cure inhibit hypnozoids, then chemoprophylactic drugs, and finally drugs preventing transmission destroy gametocytes. So first one, blood schizondicides that treat the acute attack. So the first primary choice is the chloroquine. So chloroquine is the drug of choice if parasites are sensitive, and this chloroquine is capable of destroying the trophocyte forms of all species of the parasite very effectively. Okay, and in addition to chloroquine, we can also use quinine plus doxycycline or pyrimethamine plus sulfadoxine in case of falciparum malaria. And the second class is the drugs of radical cure inhibit hypnozoids. So drugs such as primaquine can be used to inhibit hypnozoids. So we can inhibit the synthesis of Plasmodium vivax as well as Plasmodium ovale, which lie dormant in the liver. Okay, so drugs such as chloroquine inhibits the erythrocytic stage of the parasite, whereas primaquine inhibits the exoerythrocytic stage of the parasites. Coming to the third one, that is chemoprophylactic drugs. So in addition to the schizondicide effect, The chloroquine is also having chloroquine also helps to prevent the clinical attack. So in addition to the chloroquine, we can also use mefloquine and proguanil for the prevention of the clinical attack. So this prevents the release of the merozoites, which causes the clinical attack. So the inhibition of the merozoites and their further production is inhibited by the chemoprophylactic drugs such as chloroquine, mefloquine and proguanil. And the last one is the drugs which prevents the transmission, destroy gametocytes, that is primaquine. So primaquine can also inhibit the transmission of the gametocytes into the mosquito. So it destroys the gametocytes within the human body, thus prevents its entry into the mosquitoes so that its sexual phase is destroyed. So primaquine helps to destroy the hypnozoites as well as gametocytes. Now coming to the treatment of uncomplicated malaria. Malaria is treated with a blood schizoidicide selected with due and regard to the prevalence of specific patterns of the drug resistance in the area of infection. In the case of vivax and ovale malarias, subsequent treatment with a tissue schizoidicide is needed where it is considered appropriate to prevent relapse. So here is the treatment of uncomplicated malaria. In case of vivax malaria, we can manage the patient with chloroquine, which is given in a dose of 600 mg followed by 300 mg after 8 hours and then for next 2 days. So the total dose should be 25 mg per kg over 3 days. Plus we can also add primaquine 15 mg daily for 14 days. So for the overattack of malaria or the management of vivax malaria, the drug of choice is the chloroquine, right? So in vivax malaria, if the patient is pregnant, we can also use chloroquine. So pregnancy is not a contraindication for chloroquine. If the patient is resistant to chloroquine, we should use artesunate plus any powerful schizoidicidal drugs. Okay. So this chloroquine is a 4-aminochlorone drug and it destroys the trophozoite forms of all species of the parasite very effectively, right? So these drug sensitive organisms rapidly disappear on administering chloroquine and the blood smear may become negative for the parasite within 24 to 36 hours. Though the acute attack will subside, the parasites will not be eradicated. It is available as 200 milligram doses for intramuscular route as well as intravenous. Generally, this chloroquine is safe and well tolerated. You can see adverse side effects such as GI upset, allergic reactions, psychosis, convulsions, photosensitization, and ocular toxicity on long-term use. In occasional case of chloroquine resistance, we can provide quinine in a dose of 600 mg 8 hourly for 7 days and doxycycline 100 mg daily for 7 days plus primaquine. So the dose is same as mentioned above. So this quinine is the most time tested schizoidicidal alkaloid drug which is obtained from cinchona bark. So the preparation is the quinine sulfate. For chloroquine it is chloroquine hydrochloride. Okay. So the quinine is effective against all species of the parasites and it is a good alternative for chloroquine. It is available as 325 milligram tablet. Plasmodium falciparum is generally sensitive to quinine, but in many cases or many areas you can see partial resistance has developed. So when we are providing a combination of quinine with ciprofloxacin at a dose of 500 milligram 2 times daily or tetracycline 250 milligram 4 times daily, which helps to overcome partial resistance. It is better to use an alternative, more effective drugs such as artemisinin of the patients if the patient's condition is serious. So, in case of quinine use, you can see adverse effects such as bitter taste, synchronism, hypoglycemia, myocarditis, and peripheral neuropathy. So, quinine-induced hypoglycemia can be fatal if unrecognized. So, do remember that. And for the chloroquine sensitive falciparum malaria, we can manage the patient with chloroquine, primaquine in a dose of 45 milligram single dose. So, this chloroquine is a rapid acting blood schizoidicide and sometimes it is having gametocytocidal activity also. Whereas primaquine is tissue schizoidicide. Also, gametocytocidal activity is there and some activity at other stages of the parasite's life cycle. Anyway, this combination helps to destroy the parasite development in host. In case of intolerance to chloroquine, we can treat with sulfadoxine in a dose of 1500 mg plus pyrimethamine in a dose of 75 mg single dose plus primaquine 0.75 mg per kg single dose. This sulfadoxine is a blood schizoidicide. So, as we mentioned earlier, you can see there are many areas where particular resistance has developed, right? So, in such cases, chloroquine resistant falciparum malaria can be managed with artesunate in a dose of 100 mg 2 times daily for 3 days plus sulfadoxine in a dose of 1500 mg plus pyrimethamine 75 mg single dose, or we can provide artesunate in a dose of 100 mg 2 times daily for 3 days plus mefloquine 750 mg on second day and 500 mg on third day, or artemether 80 mg plus lumefantrine for 80 mg twice daily for 3 days, and it should be adjusted in child, or quinine 600 mg 8 hourly for 7 days plus doxycycline 100 mg daily for 7 days. In uncomplicated falciparum malaria, combination drug therapy is recommended by WHO for treatment in all malaria endemic areas experiencing resistance to monotherapy with chloroquine, amodiaquine, or pyrimethamine sulfadoxine. So, the drugs with a differing mechanism of action but with similar half-lives should be used to explore the parasite to a single drug for a prolonged period and to prevent the emergence and the spread of drug-resistant parasites. Pyrimethamine and sulfadoxine and atovaquone proguanil rely on synergy between two components. So here you can see the most widely recommended combinations that include an artemisinin based drug as one of the components. ACT is nothing but artemisinin combination therapy. So the recommended ACTs are artemether lumefantrine, artesunate amodiaquine, artesunate pyrimethamine sulfadoxine, artesunate and mefloquine. then amodiaquine and pyrimethamine sulfadoxine. So this is still an effective option for some areas in West Africa where susceptibility remains high and for those countries unable to supply ACTs. Now, coming to the management of severe or complicated falciparum malaria. In severe or complicated falciparum malaria, including cerebral malaria, parenteral treatment is required to produce adequate blood concentrations as quickly as possible. Patients needs to be closely monitored while undergoing parenteral therapy, and treatment is changed to an oral antimalarial as soon as the patient's condition permits. So, in case of the severe or complicated malaria, we have to provide the supportive therapy as well. So that should be directed at reducing hyperpyrexia, controlling convulsions, maintaining fluid balance, and correcting hypoglycemia. Mostly, this severe malaria is associated with rapid development of anemia, and blood transfusions are recommended for children with a hemoglobin concentration of less than 5 gram per 100 ml living in areas of high transmission, or for those with a hemoglobin level of 7 gram per 100 ml living in an area of low transmission. Coming to the prophylaxis. So how we can prevent malaria? Chemoprophylaxis of malaria may refer to absolute prevention of infection, that is causal prophylaxis, or to suppression of the parasitemia and its symptoms, that is clinical prophylaxis. Okay, so the causal prophylaxis is provided by the tissue schizonticides which destroy the exoerythrocytic forms of the parasite. The clinical prophylaxis that we will discuss later. So in causal prophylaxis, proguanil can be used as a prophylactic primarily for Plasmodium falciparum species, and we can also use bromacin as a causal prophylactic for all species of malaria. But the use of this proguanil is not employed routinely because it has to be given daily and not very effective against Plasmodium vivax. So whereas this primaquine has not been used in mass programs because of its toxic potential. So there were also trials for the use of primaquine as a causal prophylaxis. So the trials were in Kenya and Irian. They successfully used primaquine in a dose of 0.5 mg per kg against both Plasmodium falciparum and Plasmodium vivax species in subjects with normal G6PD level. So if we are providing primaquine in G6PD deficiency, that can lead to severe reaction and resulting in hemolytic anemia. And in G6PD deficiency, this leads to the increase in the oxidative stress in RBC, and this may in turn have a negative influence on the parasite. As such, individuals who possess the mutation have some protection against malaria. Okay, so those who are having G6PD deficiency, they already have a defense mechanism against this parasite, and we should not use primaquine in them. The CDC, that is nothing but the Centers for Disease Control and Prevention, recommends it only for subjects who cannot take any other prophylactic drug. Now coming to the suppressive prophylaxis. So the schizonticides which suppress the erythrocytic phase, and thus attacks of malaria fever can be reduced as prophylactics So the exoerythrocytic phase in case of vivax and other relapsing malaria continues, clinical disease does not appear. So we can manage with chloroquine 300 mg as the base or 5 mg per kg weekly. In travelers, start 1 week before with a loading dose of 10 mg per kg and continue till 1 month after return from it's written from endemic area. The last dose should be 25 mg per kg over 3 days along with primaquine 15 mg per day for 14 days. And remember that it should not be given for those who are above 3 years for the fear of cumulative toxicity. So we should take care of administering chloroquine in those who are having above 3 years. Proguanil can also be used in a dose of 200 mg daily with chloroquine. 300 mg weekly affords substantial protection against moderately chloroquine resistant Plasmodium falciparum, but less than that afforded by mefloquine. Mefloquine in a dose of 250 mg weekly till 4 weeks after return from endemic area has been used for areas where chloroquine resistant Plasmodium falciparum is prevalent. In India, use of mefloquine for prophylaxis is not allowed among residents but may be used by travelers. Doxycycline 100 mg daily starting day before travel and taken till 4 weeks after the return from endemic area for chloroquine resistant Plasmodium falciparum. So this is an alternative regimen for the individuals who are unable to take mefloquine. Especially it is contraindicated in pregnant women and children who are less than 8 years. So these were the prophylactic methods, and coming to the preventive measures. So we can prevent the spread of malaria with the use of repellents and insecticides. The WHO recommends the following measures to protect against mosquito bites. So the recommendations are application of an effective insect repellent to exposed skin, especially between dusk and dawn when mosquitoes commonly bite. Accommodation in buildings with screens over doors and windows. Use of mosquito nets at night, preferably impregnated with pyrethroid insecticides such as permethrin or deltamethrin. And use of anti-mosquito sprays or insecticide dispensers or mosquito coils in bedrooms at night. So by these preventive measures we can protect ourselves against mosquito bites. So this is all about malarial management. Hope you guys understood.